Hello and welcome. Welcome to the IPDLN 2020 medicine session. My name's Ruth Gilbert. I'm speaking to you from University College London in lockdown London. In this session, we're going to have 3 speakers, each speaking for 10 minutes, and then we'll have a 15 minutes discussion. So please send in your questions during the session and we'll be collating them and then going through them at the end. So our first speaker is Dr. Tiffany Fitzpatrick, who is at the University of Toronto School of Public Health. So over to you, Tiffany.
Thank you, Ruth. Just going to pull up my slides. Okay, so hopefully everyone can see those. So it's an honor to be here today presenting to you all. And today I'm going to be walking you through an example of a recent study that we did leveraging this really unique population-based data infrastructure for the population of Scotland, which included prescribing and laboratory data. And we used this to estimate the proportion of antibiotics that were attributable to common respiratory viruses in children. Sorry, I'm just having some slide issues. There we go. All right, so you might be aware from your own personal experiences that antibiotic prescribing is very common, and particularly in primary care. And a lot of antibiotic prescribing that is done in primary care is often classified as inappropriate or unnecessary. And particularly what I'm talking about is that for viral illnesses. So it's quite common that you go in with a scratchy throat or cough and you receive antibiotics. So this has really been a large target for a lot of antimicrobial resistance strategies. However, to date, there have been a number of data limitations which have hindered our ability to investigate some really important questions for informing these antimicrobial resistance strategies. And particularly, there have been a lack of population-based studies. So a lot of work that's been done to date has focused on hospitalization and particularly hospitalized populations. And there's been a lack of an ability to investigate community-based antibiotic dispensing. So particularly a lot of the work has focused on prescribing done in hospitals. So as we can imagine, hospitalized versus community-based populations are very different. They have very different characteristics, and antibiotic prescribing is done for different reasons. And this also means a lot of the research has focused just on prescribing and not necessarily dispensing whether people have received those antibiotics. Further, there's been an inability to look at multiple respiratory viruses. So we know that there are a whole host of viruses that circulate throughout the year, and including just respiratory viruses that circulate during cold and flu season. So with this in mind, we took the opportunity to leverage this really unique population-based data infrastructure for the population of Scotland. And we used this to estimate the proportion of community-based antibiotic dispensing among young children, which could be attributable to the circulation of several common respiratory viruses. And these included respiratory syncytial virus, or RSV, influenza, human metapneumovirus, and several human parainfluenza viruses. So if you're not familiar with these are the most common respiratory viruses that circulate each year. And particularly RSV is the most common cause of pediatric respiratory infections. So to do this, we included a number of data sets, and these were all linked at the individual level using something called the Community Health Index. So this is a unique patient identifier through the National Health Services in the UK. We identified all laboratory testing through tests that were done by NHS labs across Scotland through what's called the Electronic Communication of Surveillance in Scotland, or ECOS dataset. And we identified all antibiotics that were dispensed in primary care through what's called the Prescribing Information System. And this captures all UK citizens that are registered in primary care, which is approximately 95% of UK citizens. We also use what are called the Scottish morbidity records, and these include data on hospitalizations and maternity records, which allowed us to identify hospitalizations as an outcome, but also identify some characteristics of these children. And then finally, we included national registry data to identify all deaths and births that happened within this cohort through the General Register Office of Scotland. So just in brief, to take you through the methods used in the study. So we were interested in identifying all children under 5 years of age that lived in Scotland during our study period, which was April 1st, 2009 through December 27th, 2019. So we were interested in identifying all laboratory respiratory tests and antibiotics that were dispensed in community among this group of children. Now, as I previously mentioned, we had data on a whole host of different viral isolates through our data. And you can see all of the different viruses we had information on here. So there was a whole range of viruses. And without getting into too much detail, we performed a model fitting exercise, which identified the most important of these viruses in determining antibiotic prescribing patterns. Now, in all, we identified just over 6 million antibiotics that were dispensed among nearly 500,000 children under 5 years of age. And over the entire study period, the dispensing rate for antibiotics was roughly 625 per 1,000 child years. So it was fairly high. And our final model included RSV, influenza, human metapneumovirus, and human parainfluenza viruses types 1 and 3. So we estimated that about 14% of antibiotics dispensed in this study could be attributed to the circulation of just these 5 viruses. Now, I just want to walk you through so you can see what this looks like. So we found a very strong correlation between antibiotic dispensing rates and the circulation of the included viruses. And I just want to show why it is so important to include a variety of viruses in this type of work. So on the left, the gray line represents the weekly antibiotic dispensing rate. The dashed black line is the RSV weekly percent positivity rate, and the solid black line is that for influenza. So we see, just looking at these 2 viruses, they do a pretty good job of reflecting antibiotic prescribing during the winter months, which we would expect because these are the 2 most common winter respiratory viruses. But they're not capturing any of those peaks that we see in the spring or summer months. So as I mentioned before, a lot of the work that's been done has just included 1 or 2 respiratory viruses, and they're usually influenza and RSV. So if we just look at this, we're going to underestimate the proportion of antibiotics that could be attributable to these respiratory viruses. And to provide an example of what I mean, so we included human metapneumovirus, and this is something that peaks in the spring and early summer. So we see here that this virus does a pretty good job of reflecting those peaks in antibiotic prescribing that happen in other months of the year. All right, so some more results. I know you can't read this whole table, but I just want to highlight that because we have this linked data infrastructure, we were able to look at different characteristics that would be really important to informing antimicrobial resistance approaches. So particularly, we looked at if there were any differences according to the age of the child, if they had a history of chronic medical conditions diagnosed before their 5th birthday. So as you can imagine, antibiotic prescribing behaviors are going to be very different for children that have chronic medical conditions versus those that are otherwise healthy. We also looked at differences according to antibiotic class. Again, as you can imagine, there's going to be different indications for different antibiotics. And then finally, something I haven't mentioned yet was that in 2013, the UK introduced a 5-year antimicrobial resistance strategy. And so we looked to see if there were differences before versus after the introduction of this strategy. Now, no matter which way we looked at this, RSV was consistently the most attributed virus for the dispensing of antibiotics in children, but particularly for 2 antibiotics classes. So this included amoxicillins and macrolide prescriptions, and for children without chronic medical conditions. So these are really actionable targets for antimicrobial resistance strategies. Now, as you might know from your personal experiences, when you go in with respiratory illness, you're not always tested to confirm what virus you have. So to look at these potential testing biases, we looked at hospital admissions for pneumonia and bronchiolitis, which are largely caused by viruses, and particularly for bronchiolitis admissions, around 85% are due to RSV in children. And in this analysis, we found roughly similar conclusions. So again, supporting this idea that a high degree of antibiotic dispensing can be attributed to the circulation of these viruses. All right, so what are the takeaway messages? Well, in the study, 1 in 7 antibiotics that were dispensed in community to these young Scottish children were attributed to the circulation of just these 5 common childhood viruses. So we know that antibiotics cannot treat viral illness, and this study highlights some very clear targets for antibiotic stewardship programs. And we were offered some unique and comprehensive insights through this linked data infrastructure. Now, something that you might not be aware of, and I know we've been talking a lot about vaccinations in the media lately with COVID, but there are also a number of pediatric respiratory viruses for which there are currently not vaccines, but there are a few promising candidates in clinical trial. And particularly, I'm talking about RSV and human metapneumovirus. So if in the coming years, one of these or multiple of these vaccines are approved, this work would suggest that we would expect to see notable reductions in potentially unnecessary antibiotic prescribing in children. So I thank you for listening, and I look forward to taking your questions later on. I will note that I do have to leave, unfortunately, a few minutes early to jump onto another conference presentation. So if I don't have a chance to answer your question, please send me an email. And here's the QR code that can take you to our manuscript that's currently in press. Thank you.
Thank you very much, Tiffany. It's so nice to see a Canadian presenting data from Scotland. That's exactly what we should be seeing, facilitated through the IPDLN. So we're going to move on now to Dr. Louise Schreuders. Louise comes from the University of Leeds, but originally from Australia, and she's going to tell us about prescribing for atopic eczema in children. Over to you, Louise. Louise, are you there? So we should have.
I'm really sorry about this. I was all ready to go, and then my computer just froze because, you know, that's what we do in these moments, of course.
You're able to get your slides up, Louise?
Yeah, I'm sorry. You always hope you're not going to be the one that has the technical difficulties, and I thought I was ready to go. Okay, here we go. I think I'm sharing okay now. Is that all right?
Yep.
Great. Thanks, Ruth, very much. And thank you so much, Tiffany, for your presentation as well. So this project is a couple of years old. I was working on it back at the time of the last International Population Data Linkage Conference in Banff, actually. And it's also one that's close to my heart because my children both have eczema as well. And so I found it really excellent to immerse myself in all of the best practice data about treating children with eczema, and it's definitely helped us cope with our personal eczema journey as well. The project was kind of like a pilot development project, which was funded by the Yorkshire and Humber Academic Health Science Network, and it was this sort of exploratory project to try and use some of the data that's generated from the this system, the input system that is run in most of the primary care practices across the UK, called System 1, and they have a research arm called Research 1. And this is the coverage of that system in England. So you can see that every county has a representation of use at least one primary care setting using System 1. And I gather they have them. They're an international organisation as well for people who use it. So we had this data, and our primary. So the reason I'm sort of giving that background is because the project had two elements to it. It wasn't strictly speaking a data linkage project. It was an exploratory project to find out about how we could potentially use this kind of data for linkage to sort of, you know, secondary care setting data and that kind of thing. And the Research 1 have gone on to do that, and they have had some excellent data that's been made available through the Open Data project, which is to do with all of the COVID analysis that's been happening, which is, I think, done with Imperial College with Ben Goldacre. I'm not quite sure if I've got the university right there. So anyway, back in 2017, when we were doing this, our interest was on the topic of dermatology. And so we accessed this dermatology data for children, and we identified within the data set those children who had been coded for having atopic eczema. So a bit of background about what that is. It's a childhood disease that a lot of children grow out of, but it can affect people into adulthood. It's an inflammatory condition of the skin, where you can see these two examples of, sorry, maybe I should have put a content warning on that. You can see these two examples of children who are having quite a severe flare-up, and it is characterized as kind of like these flare-ups and then settling down and then a flare-up again, which is triggered by various things. They're not quite 100% sure exactly what triggers all of the eczema flares. But it does affect a lot of children, between 20 and 30% of UK children. And the international data all sits around that kind of 2 to 3 in 10 children being affected by eczema during childhood at some point. So in 2007, there were best practice guidelines for the diagnosis and treatment of eczema for children. And data since then has kind of indicated in the literature that, you know, up to 37% thereabouts of children are not receiving the optimal treatment based on what we know is the best way to get on top of the eczema, which is a combination of topical emollient, and then for the flare-ups to get prescribed a topical corticosteroid. And there's like, it was really interesting reading the data about that, because there was kind of this tension between reports from parents about how difficult it is to comply with the regime, treatment regime, because I don't know if you've ever tried to put something slippery on a 2-year-old at bedtime, but it's a real challenge. And then there's also from the health professional perspective, them saying like that, you know, it's hard to get compliance, and maybe parents don't understand how important the emollient, you know, 3 or 4 times a day can be for a child such as this baby who's got this really severe flare-up happening now. So that was quite an interesting thing, you know, personal finding. So the size of this problem, as you saw from the previous slide, there was representation in our data set from all of the counties across England. And this was the number of appointments per month where eczema was documented for the first time in a child who was 12 or younger over this period of time from, I think I might not have mentioned that, from 2003 to 2013. And so there were at least 900 first-time eczema diagnoses per month. In the primary care setting. So it's a lot for 300-ish children to be not getting the best, you know, not showing a regime of getting the best treatment. Also, although it's not super clear here, but there were fewer children, like around the 850 mark on average at the beginning of this follow-up period in 2003, and then towards the end in 2013, they were sitting at you know, just over 1,000 per month. So it's affecting a lot of children. So we had the idea that we could use routine primary care data to inform a decision support tool for practitioners, which would improve the application of the dermatological research evidence. So basically we would have something embedded within System 1 so that if certain criteria were met by that individual that was presenting to the healthcare practitioner, that there would be some trigger for them. And because this was a like test case scenario, we were kind of, oh, hang on, I'm going ahead. Yeah, sorry, I've lost my train. So the first step for the research was trying to look at what the best practice flow was. And so we made this visualization for, this is the NICE recommendations, which in some ways gives us an indication of why they might not be particularly well followed, because this is the pathway that you might have The most common presentation scenario was a child with mild to moderate areas of skin redness and itching. And these children are supposed to be prescribed emollients and topical corticosteroids, potentially with a referral, but typically they are given the best practice prescribing and then seen again to see whether or not that's had an effect within 2 weeks, and then the referral pathway goes on from there. So we were capturing this within our data based on what was prescribed, what was noted as having been prescribed in the primary care data. So we were quite fortunate that we had information about prescriptions in our data set. So we identified the four sort of pathways. There was the best practice standard, which is children were prescribed emollient and steroids. There was the emollient only, the steroid only, and then no prescription given to the child. Now that could in some cases be because the emollient is available over the counter. And so if the family weren't able to comply with the what was available by their GP, they might have asked for, gone for something different of their own accord. So we can see that if we compare just the block of time before and the block of time after when the NICE guidelines came out, there was a definite change where there was a 8% increase in sort of NICE aligned best practice prescribing compared with a decrease in the non-ideal prescribing scenario. But we were interested...
We're going to have to finish up very shortly. Can you wind up, please?
Oh, sorry. I thought I still had a couple of minutes to go. Okay. I'll skip ahead to the results that we found. So basically, we did a time series analysis to look at whether or not the differences that we were seeing before and after was a result of the change in trend. And we found that although there was definitely an increase in the NICE prescribed, NICE advised prescribing, it was a result of a pre-existing trend, and probably the NICE guidelines represented more of a codification of the ideal best practice rather than leading to ongoing best practice. So yeah, I'm sorry I must have misjudged my timer, but here we have a preprint of our results, which we're preparing for a journal at the moment, and if you want to check it out, you can follow this link, Childhood Eczema 2020 preprint. Sorry about that, Ruth. Thank you.
Thank you, and fantastic data you've got access to there. So great. So we're now going to move on to Dan Chateau, who is from Manitoba, and he's an associate professor at the Manitoba Centre for Health Policy, and he's going to talk to us about benzodiazepine prescribing in pregnancy and the effects on ADHD. Over to you, Dan.
There, I'm not muted anymore. You can hear me now. So the title says it all. We're looking at benzodiazepine use during pregnancy and the risk of ADHD in offspring. Just to let you know where I am in fact, right, let's get this to move forward. There's Canada. Manitoba is the center of Canada, the most important province. Winnipeg is the star there. That's like most Canadians, we mass our population within 100 kilometers of the US border. We're preparing for invasion, although maybe not right now. And I work at the Manitoba Centre for Health Policy, which houses a lot of de-identified administrative data, similar to ICES in Ontario and institutions in the UK and also in Australia. Today, we're mostly just using health data, but we do have access to a lot of other data as well. And let me also say, before I keep going, a couple of things. One, the University of Manitoba is located on the original lands of the Anishinaabe, Cree, Ojibwe, and Dene peoples. And as an institution, we're dedicated to moving forward in the spirit of collaboration and reconciliation. And as on another note, today is National Holiday, well, particularly here in Manitoba, celebrating the ultimate sacrifice of persons in the armed forces. And so those ceremonies will be taking place at 11 a.m. It's 10:25 right now, so I better move along. Okay, so why are we doing this? Well, just before this presentation, I decided to find out what had happened since I had started doing this, and lo and behold, somebody else has published on it, of course. So let's take a look at why they published. You know, and these will steal from people who've managed to get through the peer review process. So it looks like, you know, benzodiazepines and Z hypnotics. I say Z. If you're American, you say Z. I'm not sure what everybody else says. Hopefully it's Z. So Z hypnotics, both medications may interfere with fetal development. And so there is some reason to believe that they could have an impact on neurodevelopment. And as they point out here, there's been really very little research looking into this. And of course, part of the reason is because nobody is doing randomized controlled trials on exposing pregnant women to various different drugs. So it's pretty much all up to observational studies. Now, this particular study identified 283 exposed children. And in the end, they decided that benzodiazepines and Z hypnotics were, you know, really, there was no risk. So I had already done my analysis, so I'm going to tell you about it anyway. As I said, in the absence of randomized controlled trials, the observational studies by default become the gold standard. And one of the critical issues is confounding by indication. Right? The reasons that you're taking the medication are likely related to almost every possible negative outcome that you could imagine. And so a lot of previous studies do have an issue with confounding by indication and other problems as well. Our big effort here was to try to address those. And so we're using some methods to try to address, you know, disease severity, some longer term follow-up, and smaller sample sizes. In the end, you know, out of 315,000 pregnancies that we looked at, you know, we were down to 172,000 that we needed at least 5 years of follow-up because ADHD doesn't happen when you're one. And in the end, we ended up with 479 women that had exposed to 2 or more benzodiazepine prescriptions during pregnancy. You may ask why 2? The reason we want 2 or more is that we only have dispensation data. And so if you get dispensed a benzodiazepine, it doesn't mean that you took any of them. But if you get dispensed a second benzodiazepine, you probably took all of the first one. So it's a little bit of a measurement error correction there to make sure that we've got an exposed group and the unexposed group numbered in the thousands. They were pretty different to begin with. If you take a look at this, can I get a pointer working? Maybe I can get a pointer working. Maybe not. Oh, yeah, maybe I can. So, you know, the women who had 2 or more dispensations, they were older, a little bit higher socioeconomic risk. They also were more likely to be urban, and importantly, they had a much higher rate of ADHD themselves and epilepsy. Probably not surprising, they also had a slightly higher rate of inadequate prenatal care. And the children were also somewhat different, particularly when it came to preterm birth and low birth weight. So there is a big difference there between, you know, the thousands of women that didn't take benzodiazepines and the women that did. And this is where we run into our issues of confounding. So one of the things I've been using as part of a Canadian network examining drug safety, the Canadian Network of Observational Drug Effect Studies, is the high dimensional propensity score. And this is a machine learning algorithm that kind of scans all of your health data to look for variables that are related to both the exposure and the outcome, so true confounders, and then it prioritizes them by the risk of bias. So it actually takes a look at the relationship between the two, ranks them on bias, and then chooses those variables that are most likely to contribute to bias. And lo and behold, it tends to do a really good job. So we ran this, it generates propensity scores, then we did a propensity score match. Here are standardized differences before and after the match. So remember, it's going and mining the data to find things that are related to both the exposure and the outcome. And it turns out that, you know, things like zopiclone, clonazepam, clonazepam, all the PAMs really, were all related to exposure during pregnancy. So this is all prior to conception, all of these variables. They are related to exposure during pregnancy, not surprising. They're also related to the outcome. And then other things such as, you know, physician visits for neurotic disorders, physician visits for general symptoms, depressive disorder, disorders of the back, and visits for epilepsy. So our standardized differences before are these blue lines. They are fairly large. After we matched, they're quite low. And so in fact, if you talk to Peter Austin, anything less than 0.1 is considered negligible and of no concern. So we're doing good there. We used a proportional hazard regression analysis for our outcome models. We did have variable follow-up. And so we start at 5 years, actually. So 5 years of age, looking forward, how long before the child ends up being diagnosed with ADHD or censored at the end of follow-up. We also entered some variables that weren't part of the propensity score, and those were birth outcomes. These couldn't be part of a propensity score because that propensity score we actually used prior to conception, so the 1 year prior to conception. So these are more birth outcomes. Now they could be a path along the way to the outcome. So it could be that we're over adjusting, but nonetheless we put them in. So premature, small for gestational age, the inadequate prenatal care, and then importantly, the history of ADHD in the mothers. So I'm trying to move it along here to make sure that we finish. So here's the main result. So we've got our matched cohort, got women with 2 or more benzodiazepine prescriptions in pregnancy compared to women with none. In the end, out of the 479 women who were exposed, 464 we were able to find a match for. So there were 15 moms who, it would appear there's nobody like them who didn't take a benzodiazepine, so they probably really needed the benzodiazepine regardless of the risk of any adverse events. There is a much higher crude incidence. You can see it's 25% compared to 18%. Now that at first seemed really, really high to me. It is high. In the population at large, it's about 7% of children get diagnosed with ADHD, which I think is really high compared to other jurisdictions. I'm not positive about that. It's about 7% though in Manitoba. We ended up with 25% in our exposed group, 18% in our unexposed group, and a hazard ratio of about 1.9, which was significant. And remember, this was after the match and then also adjusting for the mother's history of ADHD and the birth outcomes. So it seemed fairly strong. We didn't stop there. Like any good, pharmacoepidemiological study, you have to throw in a whole bunch of sensitivity analyses, keep looking at it a million different ways. One of the first we did was a negative control. And so what this means is we identified women who were using benzodiazepines just before their pregnancy, so just before conception, and a group of women who weren't using benzodiazepines. And of all these women, none of them used benzodiazepines during their pregnancy. So this is kind of an estimate of how much of our effect might just be due to residual compounding. So there could be a difference between women who are using benzodiazepines and women that don't. So let's take a look at groups of women who are using benzodiazepines just before pregnancy, and then see if we find an effect, even though none of them used a benzodiazepine during their pregnancy. And you do see a much reduced hazard ratio, although it's not nil, right? It's still 1.3, not significant. It is a smaller sample size, could be a power issue. So there might be some residual compounding still there. We have to take the 1.89 a little bit with a grain of salt, but our confidence interval there can withstand this kind of residual compounding. Additionally, we took a look at women who were using benzodiazepines immediately prior to conception. So they were all using benzodiazepines in the 90 days prior to conception, and then some of which continued to use benzodiazepines, some of which didn't. In that group, you actually see, again, a significant relationship between the benzodiazepine exposure and the risk of ADHD in the offspring. It is attenuated. It's not as large as what we saw previously. So there's still some indication that maybe our 1.9 was a bit of an overestimate. And last but not least, we did a sibling analysis. Now, this one is very different. And it's different in how it was done, not just the outcome. The problem with the sibling analysis, unlike the rest, is you can't really run a high-dimensional propensity score in this case, right? So, and you probably, hopefully don't need to because it's the same mom, but things change between pregnancies. So to the best of our ability, we tried to adjust for stuff as much as possible, but you obviously can't adjust for pregnancy order or anything like that. It is a much attenuated hazard ratio. We're down to 1.2 and non-significant. So we've got a little bit of a dog's breakfast here in our outcomes. The initial analysis, which we have some confidence in, is a fairly large hazard ratio. The sensitivity analyses suggest it's likely somewhat smaller, maybe not nil, maybe it's lower. So we do add, a large population-based sample. We about doubled the number of exposed pregnancies over that prior study that I pointed to at the beginning. We tried to use, this machine learning algorithm to adjust for confounding, and we carried out multiple sensitivity analyses. In the end, I think we need another couple of jurisdictions to carry out the same kind of study to increase our power, particularly for the sibling analysis and the positive control, negative control. I think it would certainly be helpful to see this redone in another jurisdiction that has the same kind of data that can contribute further to it. And so I think I've got a questions and comments slide, but I realize now this is useless because although luckily I'm last, so I should put this slide up now because I believe now it's time for questions and comments. Thank you.
Okay, thank you very much, Dan. That's great. And I think you're asking your questions in the right place about further analyses of the same question. If you're moving to Australia, maybe you can do it there. So we're over to questions now. We have 15 minutes for questions. So please put in your questions in the question and answer session.
How do I stop sharing?
So I'll start with you, Dan, as a question just while people are starting to put things in. So where would you consider doing this that would have similar data to the wonderful data that you have in Manitoba, that you could do the sibling comparisons and the sensitivity analyses that you did, and you'd be using prescribing data in the community?
Well, what immediately comes to mind as a Canadian is all of the provinces west of the Manitoba-Ontario border, because it seems to be a magical line there. West of that line, all the provinces have prescription data for the whole population, and that line they don't. And so east of that line, it's only for the population over 65 or those on social assistance, income assistance. So, I think British Columbia would be a target for this kind of study. And I have a colleague there who's working on a different pregnancy exposure study with me, and that's on opioid exposure. So maybe I can convince him to fall into line with this. We did this analysis, kind of haven't looked at it since it was completed because there's been other things going on. So now that I was forced to put together a presentation for IPDLN, because I submitted an abstract, I'm thinking it would be good to get back to that and talk to him about doing it there. I think maybe the CPRD, they've got the gold and the Orem now. That might, I'm not sure how much information they have. It needs to be a jurisdiction where you can attach a mom and a baby together. Right? And not all jurisdictions can do that.
So CPRD, certainly you can join up mothers and babies, and you've just been hearing from the presentation that Tiffany did with Scottish data, you can do the same. So I think, you know, there's plenty of possibilities there. Okay, so just a bit of feedback, Dan. When you was presenting, you moved your head. We found it hard to hear, so maybe people didn't all pick up on everything.
Yeah, that could be me moving my head. It could also be that I've been having problems with the audio card in this computer, and it's been happening in scenarios as well. So I apologize for that.
Can we go to, there's some questions for Tiffany. So one here that is, are there any takeaways in terms of using laboratory and prescription data from Canada to do a similar type of study? So I know, Tiffany, you've got to go early. So can we go over to you to answer that question from Lisa Licks?
Yeah, sure. So I think Dan just alluded to my answer here, that they're very rare to get your hands on population-based lab data and testing data in Canada. So there are a few provinces. Being from Ontario, I can say that we could do this study for 2 years in Ontario. So there was a 2-year period where we had the expansion of our provincial health insurance plan to include all drugs, or an essential list of drugs for children under 18 years of age. So we could do that for 2 years here. Probably wouldn't be enough at time points, though, to get the granularity that we need. Oh, I'm sorry. I have an alarm going off here. I'm so sorry. And then we also have lab test data here too, but it's not entirely population based. It's just labs that have been reported to our provincial public health laboratory. So some hospital-based labs don't report to that.
Okay, so really unique data. Thank you. So I've got a question for Louise. If you're still there, Louise. You mentioned in your abstract, and didn't get a chance to say in your talk, about that you were the first to use the System 1 data for this purpose, and reading between the lines, there were quite a lot of challenges. But are other people going to be able to use that data? Could you tell us about that?
Yeah, sorry, I got a bit thrown off by my technical difficulties at the beginning, and then I kind of like glossed over my take-home message, which is just, yes, when we got access to this data, there were a suite of other projects as well that had access to System 1 data that worked on other projects as well that were set in primary care. And I think that what it really revealed to me, undertaking the project, was having come from a background in Western Australia where the data linkage infrastructure is really like set up already well, and this was kind of like a first time that these kinds of projects were being undertaken in the UK, or at least at the vanguard of that being undertaken, certainly with primary care data. I think that yeah, there have been ongoing projects now, and some of the things that were learned by undertaking this process with us, or with the other, you know, our project and the others that were funded at the same time, was what were learned and have gone on to mean that this data is getting used as a source from Research One more widely now. And like I said before, it's called the Open Safely project. They have used System 1 data as part of the COVID response analyses that have been taken with UK data. I think that definitely, like, having that infrastructure of, because this data had never been used in this way before, there weren't the like feedback loops where you could say, oh, I'm noticing this anomaly, who do I contact within the organization to make, you know, to be able to rectify that. So it was very much like a kind of a learning process for being able to make sure those, I've really taken that kind of infrastructure for granted in previous data linkage projects I've done in different settings.
Yeah, and I don't think you told us the total child population covered by the data overall. Do you have that in your head?
I don't have that in my brain right now. I just there was representation from all of the counties across the country, and around 900 per month. Yeah.
Yeah, no, that's absolutely great. Okay, well, maybe others can follow where you've been, because that was it does sound excellent. And do they link mothers and babies? Just to answer Dan's question.
I don't know. I was thinking about it while I was listening to Dan's presentation. I'm not sure that they do have that data accessible for research purposes, but it's a fast evolving area here, especially because of all of the things that are going on with COVID. So maybe.
Yeah, maybe that's something they need pushing on. So we need someone who's good on advancing data innovations there. Okay, and have we got any more questions coming through from others? While we're waiting, I've got another question for Dan. Dan,
sorry, can I say bye? I just need to jump off to that other call. So if anyone has any questions, feel free to email me. Thanks, everyone.
Bye.
Bye, Tiffany.
Bye.
Bye. Dan, you raised the question that this was a particularly one of the risk factors was the teen pregnancies. You want to say a bit more about that? So your particular risk groups that for the benzodiazepines in your abstract.
Yeah. Yeah. I'm not sure what I would want to say about that other than, you know, there's a lot of benzodiazepine use in Manitoba, probably more than there should be. And so, I mean, in some ways as a researcher, that's a good thing, but from a social perspective, probably not a good thing. Why teen pregnancy is a particular risk factor for use of benzodiazepines, I can only say that it's likely more an indicator of other social determinants of health that are all factors for the use of benzodiazepines. Mm-hmm. So, you know, there's also things like living in social housing, being on income assistance, mm-hmm. Low income areas, moving around a lot. We've been able to look at a whole bunch of these other kind of social determinants of health, and they all contribute towards the use of things like benzodiazepines and other psychotropics. So very likely in this particular case, it's really an indicator of an SES kind of social determinant that is a predictor of benzodiazepine use overall. It's not particular for pregnancy, but obviously it comes up when you're doing a research study on pregnancy. So that's what I would say there.
Yeah, I think there's another question from Lisa Licks, which is, can you comment on the potential for unmeasured confounding? Any key variables you wish you had in the data that were not available?
Ooh, wow, Lisa with the tough questions. Now you see, she's a colleague. I know Lisa. Thanks,
Maybe
Lisa.
The answer.
Yeah, key variables that I wish I had. Yeah, I'm just trying to think really hard about what would have been something really that we didn't have access to. I think that if we had, so the prior study actually had questionnaires and they were able to ask moms questions. Some of the things that we don't have are other non-prescription exposures that could be related to fetal development. So we don't have smoking, number one, or other illicit or illicit use of substances that aren't covered by our drug program information network. So those might be some variables that would be nice to have. The hope with something like the HDPS is that it captures a lot of that through health proxies. And there is a presentation by a colleague, Naomi Ham, here at IPDLN. It's not a live one, I think it's recorded, that looks at the ability of the HDPS to capture those social determinants of health. So we're hoping we did a really good job there, but those other exposures might be ones that we would want to be able to measure. And unfortunately, you know, administrative data doesn't capture smoking or other drug or alcohol use unless it meets the threshold of a clinical diagnosis.
Okay, thank you. I think we haven't got any more questions, so and I've run out of questions too. So I think it's time to wrap up and say thank you very much to our speakers. It's been a really interesting session and fantastic data you've all been working on and great ways of analysing it. So I have to Dan's pointed to other videos on demand and posters that are in the on-demand gallery that may be relevant to this session. But otherwise, I just say thank you very much and look forward to meeting you in another session. So,
thank you, Ruth. Great job.
Thank you for sharing, Ruth. Thanks.
Bye, everyone.
Bye.
Bye.